Well, I'm Dr. Jim Del Rosso, a dermatologist in Las Vegas, Nevada, and editor-in-chief of the Journal of Clinical and Aesthetic Dermatology, which we all affectionately call the Green Journal. And we know it's your favorite peer-reviewed index journal with chock full of information. Today, I have with me a very good friend and colleague from Las Vegas, Dr. David Cotter, who has quickly gone from being someone in the trenches, seeing a lot of patients in dermatology, to really being well known for a lot of the things that he's doing. And when I think back to, I knew David for quite a while, but thinking back to last fall, we had our Nevada Society of Dermatology and Dermatologic Surgery meeting, in Lake Tahoe, and that's a society you're going to be hearing more about. But at that time, we had a meeting. David was involved in organizing the program. He's the president of that society this year, and I had noticed that there were some posters in the hallway, and one of them, he was the last author, meaning the senior author on it, and there were some students that were on the poster, and I'm looking at the poster, and it had phenomenal information. And I'm thinking to myself, it's going to sit here. Probably not a lot of people are going to see it. And then after the meeting, this really, really great information. And there were other posters too, but this one really stood out to me because of what it did. And I said, David, we need to get this as a publication. Why don't you get together with the students, submit it, get it to me, and we'll see if it has to meet the peer review criteria and hit a high bar for inclusion. But why don't we do that? And he did. And it's now published in the January 2026 Journal of Clinical and Aesthetic Dermatology, which I'm holding right here. And it's entitled Clinical Management of Dupilumab-Related Conjunctivitis, Erythema, and Arthralgia in Atopic Dermatitis. Evidence from 2 cases treated with nemolizumab. Now, let me say up front, we're not here to throw stones at dupilumab. We're here to look at situations where a certain therapy may have some difficulties or it didn't work out for patients, and that can happen with a lot of different drugs. This is just an example of where it happened with dupilumab. And so what are you going to do next? And that's where the teaching comes from a lot of these case reports, because we don't have the big phase 2 and phase 3 double-blind placebo-controlled studies to answer a lot of these questions. So, David, let's talk about these cases, and also you can throw in any other examples from your experience, and I'll do the same. I found this to be a very revealing article. And we could start with the first case. That was the 11-year-old that had very severe atopic dermatitis. She had 10 out of 10 severity on the itching. The body surface area was about 40% of her body that was involved. She had been on various OTC medications and moisturizers and topicals. And she had 6 months of dupilumab, which was doing pretty good, but she developed true conjunctivitis, where we as dermatologists can actually see what's going on, and worsening of facial erythema. And then you went through switching her to tralokinumab and eventually getting to nemolizumab. So Jim Del Rosso has already talked too long, and we're going to turn it over to David Cotter and go through what the thought process was on this case with the medical students. And I'll call out Aaron Cheng, who is applying to dermatology residencies right now, I believe, and does a phenomenal job when he takes on these cases. So David, help me out here.
Well, thanks, Jim, for that lovely run-in. That was such a nice primer on all the great things going on in Nevada and the good work that we're all doing with our students, which is so important to be involved in mentorship. I'm both a mentor and a mentee, and you've helped me along the way with my career, Jim, and I'm grateful for that. And thinking about these 3 students on the case, they all work really hard. And you're right, Aaron is applying to dermatology this upcoming cycle. And thinking about balancing everything, being in the trenches, seeing a lot of patients, also doing clinical trials, and also consulting and advising has enabled me to have access to dermatology in a lot of different ways. And that really has positively impacted the patient care, particularly when I see a difficult case like this 11-year-old woman, this young lady, because she came to me essentially already done well on one biologic, but was limited by a side effect. And the next logical step, particularly for this young lady, was to switch to another biologic. especially because when we first met, she was under age 12, and we used tralokinumab off-label in that age range. Because it was FDA approved down to 12, it was our second biologic we had approved for atopic dermatitis, and I felt very comfortable giving it to her as a next step option. Unfortunately for her, Jim, she never got completely clear. Tralo is one of these medicines that works very well, but it's a little slower to start than some of our others. We like to give it a good run in. I say 6 months on Tralo before you truly know. And she'd done okay. She'd had some intermittent flares along the way, but was slowly improving. But unfortunately, ultimately, after a year on this medicine, her course was limited, not just by incomplete clearance, but also recurrent conjunctivitis.
What I saw there though, Dave, was that you can, it sounds like, oh, you easily find out, like it's a light switch. They're either doing a lot better or a lot worse, but they can sometimes trickle along and seem like they're doing pretty good. So you continue the therapies till you finally get to this answer after a period of time that you mentioned, where she really didn't get as much control as you would like of her disease, though the atopic dermatitis itself, but these adverse events came through. The facial erythema was very brisk. You can see it in the photographs at that point in time. The conjunctivitis stayed, and she also had patch testing, which showed a very difficult allergen. Composite is so many different things that can be airborne, so that was complicating it for her even further. And the Trello wasn't controlling that. So, that added on to it, correct?
You're exactly right. This is a very complicated case for a variety of reasons, including her composite allergy. She certainly had an airborne contact dermatitis component to her disease. And this case is a few years old now, which gives us the benefit of hindsight. The therapeutic landscape for atopic dermatitis evolved as we were treating this young lady, meaning that she'd been on Dupi. We were able to get her Trelo. And for a while, the only medicines that were approved were Dupi, Trelo, and then JAK inhibitors, upadacitinib and abrocitinib. And typically, when I see someone who has a composite allergy in the setting of difficult to control atopic dermatitis, those are patients that I almost always reach for a JAK inhibitor for because it gives you more broad control of the inflammatory milieu. And a lot of times you do need that for these composite allergic patients in my past experience. But for her, Jim, there was not a chance this woman was going to go on a JAK inhibitor. And one of the reasons is she has an indwelling VP shunt. So essentially a connection between her brain and her peritoneum. And it has to do with her being a very extreme preemie when she was first born. And with that type of indwelling hardware, both her and her mom were very concerned about the potential for an infection if she were to go on a JAK inhibitor. In this clinical case, we saw that her itch was reduced very rapidly. It went from severe itch down to an NRS of 2 by week 4, which is just after one dose. And additionally, she had marked improvement of her facial erythema, scaling, lichenification, and periorbital swelling by just 12 weeks on nemolizumab.
And the conjunctivitis resolved too. I mean, it dramatically improved, it was gone.
And she's had no conjunctivitis, Jim. I followed her now for at least another year since she's started nemolizumab, and we've had no recurrent conjunctivitis.
So what I see in this case is things that you already mentioned. We know from with nemolizumab, just thinking about it being anti-IL-31 and not for 13 IL-13, IL-4 inhibition or both, it spares involving the goblet cells and the cells within the eye where you can have secretions that you need to prevent your eyes from getting too dry and affected. So in the clinical trials, that did not emerge as any more than the placebo because atopics can have conjunctivitis and ocular surface disease low level, but it's there if you look with a slit lamp related to the disease. So that was a great choice just to be thinking about getting around the conjunctivitis. But I think a lot of the patients, and I can tell you from having injected myself with these different devices to feel the difference, the nemolizumab, it's a very thin needle. You practically do not feel it, but it has a low volume. It's only a half of ml of injection.
Let me tell you about that, Jim, for this patient. It was actually a very poignant component of her case. The day that we started nemolizumab for her in the office, her mom wanted her to have immediate control. She wanted her to have rapid itch reduction. And we knew that we needed to switch her systemic therapy. You can see what she looked like if you pull the paper on JCAT and look at figure C. She was not in a good spot. And the patient and the mom both agreed to start nemolizumab in the office that day. The dosing is pretty simple, as we all know. We crack the sample pen, which, as you know, Jim, is a dual chamber medicine that has to be activated. And we get ready to go. We bring it in the room, and she's refusing injection. She is so worried about injection pain that she's absolutely adamant she's not going to start it. Her mom, myself, and one of my key MAs talk her off the ledge a bit, and she agrees to do her first injection in the office. She's laughing hysterically. She's got tears of joy. She goes, "That's it? I didn't even feel it." So here's a patient that was on two prior biologics, refusing to take the sample injection in the office because she was so worried about the pain, immediately flips to laughing hysterically because she couldn't believe that it was so painless.
And I can tell you this is not an exaggeration because I've experienced that myself. I don't even know I'm getting the injection. One time I felt a little pinch, and that's it. And the volume, you're not displacing much. There's a big difference between displacing a half of ml of tissue by the liquid and 2 mLs, especially if it's not allowed to get down to room temperature and people are injecting it when it's still cold. I mean, there's a lot of reasons why it's not just an immunologic reaction with swelling and redness when you talk about injection related side effects. It's this experience of taking the injection. So I'm so glad that I'm not the only one that has noticed that's and in kids that's good. In anybody it's going to make a difference, but in kids, you know, that's a big deal.
Yeah, it's a big upside to have the low rates of injection site pain for these patients.
So we'll fast forward now because you had a second case. You had a 22-year-old female that a woman that had atopic dermatitis for years and since childhood gone around the block with a lot of different things and had been on dupilumab for about 6 months and I believe was also doing well overall, but developed she had still had some significant itching, but she developed a face, neck, and upper chest with periocular involvement, visible periocular involvement, that worsening of erythema, especially on the face, but can be involved in other areas that we hear about with dupilumab in some cases that tend, even when everything else is getting better, it just does not go away. It lingers. In fact, sometimes gets worse. And then she developed some joint pain, which was interesting. These things are now in the label with dupilumab. The facial erythema, worsening of erythema, arthralgias are in there. The joint pain is in there, and that those are now now mentioned in the package insert as a possibility. So in this case, you went right to nemolizumab from dupilumab. So what was your thinking there as opposed to going to another drug in between, or had we advanced further in our understanding of the landscape, as you mentioned earlier?
Well, this was an interesting case because, like you said, she'd had atopic dermatitis for most of her life. She'd been on Dupixent for about 6 months. And during that time, she developed worsening facial erythema and some worsening pruritus in those regions as well. And she'd cycled through topical and systemic steroids at other offices before she came to see me for a second opinion. And when she presented, she had striking facial erythema. She had a lot of facial dermatitis. And I'm again thinking about her landscape. I'm thinking about what her primary concerns were, which was to avoid side effects and also to help resolve that prominent facial dermatitis.
And if I remember correctly, David, she had significant pruritus and she had involvement on her extremities, antecubital upper extremities.
Absolutely. She still had textbook atopic dermatitis. There was AC fossa involvement. She had flexor neck involvement. There was still plenty of atopic dermatitis, popliteal involvement as well. So clearly she had AD. And the question became, did she have something else going on in her face? Was it a dupilumab reaction? Was it undiagnosed contact allergy? In either case, she also was experiencing some arthralgias, and there was a lot of concern about starting any next medicine because she'd already had side effects from her first one. And a lot of these patients, when they see me in referral and for second, third, fourth opinions, they're reticent to start additional therapies because they've already had something that causes side effect and they want a medication that's particularly clean. Drawing from past clinical experience and clinical trial data, first of all, I thought we should stop the dupilumab right away because it was clearly causing at least one or two side effects. But then picking the next therapy, I wanted to put my best foot forward for her. We'd already had great clinical experience in clearing facial dermatitis with nemolizumab, as you saw in the first case and others that we haven't reported. That's something we do all the time in the office. But beyond that, I was thinking about what else could we do for her? We could put her on a JAK inhibitor. We could put her on Trelo. We didn't have Lebri at this point in time when this case was available. And thinking about getting her under control quickly, I knew that itch was a predominant component of her disease state. And that kind of pinned me down to either doing nemolizumab or a JAK inhibitor. But in this case, the patient chose to go on nemolizumab, which was a great option for her to have the safety as well as the rapidity of response from a pruritus standpoint, which is why we picked Nemo for her. Additionally, because she had concerns about side effects. This is a patient that had arthralgias and had facial dermatitis on dupilumab, and we wanted to pick something that had the cleanest side effect profile we could come up with. And when we think about what Nemluvio offers from a safety profile, it really does lead the therapeutic landscape. When you look at the placebo-adjusted rates of side effects for Nemluvio at week 16 in the Arcadia trials, it's super clean. It's one of the lowest safety rates I've seen ever. We're talking about patients that have headaches, arthralgias, urticaria, and myalgias all at 1% or lower. That's only four side effects that are being reported for a biologic. And again, thinking about her overall goals, rapid itch reduction, she was gun shy to start another medicine because of her past experience with side effects from her biologic. That when I was looking at our landscape between picking a JAK inhibitor versus nemolizumab as her next step in therapy, it made a lot of sense to go with nemolizumab.
It did, and it's not all or none because let's say the Nemo didn't work out, you still have those other options that you can go to, right? So everything you said, I think, makes a lot of sense. I think the conjunctivitis part of it is is major, but also the fact that she had the joint pains, and we you certainly didn't experience that with nemolizumab. But her response was very rapid, also, like that first case. I believe within the first month, she went from a 10 out of 10 on the itch to a 2, and then by 2 months had complete resolution of the facial erythema, the joint pains, everything cleared up. And at least according to the paper, at 7 months out, she was fine. Occasional headaches here and there, which we don't know is what they were related to, if it's even related to the drug, and they were not incidental to changing anything. So I think it's another great example of where nemolizumab does fit a different profile compared to some of the other choices we have. The mechanism has a lot to do with it, and it works out when you look at the data. So I think these are two great cases that provide, and that's why we're doing this at JCAD, because you can't glean this from the bigger large scale studies. Getting these case reports where people can show this is what we did and this is how it worked out, and getting collections of them over time. So I'm hoping now that you're a big shot associate editor of the JCAD, which you certainly earned. We're very happy about it. The staff is really happy about you doing that. You're going to bring on more of these great cases with your students and residents, correct, David?
I certainly hope so, Jim. It's been a great relationship so far. And thinking about these cases, the second woman, she's still on nemolizumab today, doing extremely well. And for both of these cases, Nemo wasn't the first line therapy, and for a couple of reasons. One, they both came to me in referral. And for the first case, Nemo wasn't even around when we initially started her, but they do drive a couple of very important teaching points. The first one is that when you switch from a 4/13 inhibitor or a 13 inhibitor to a 31 inhibitor, you may not just be biologic cycling, you're actually switching mechanisms of action. And both of these cases, as well as many others that I have in my clinic, and I know many of my colleagues do as well, demonstrate that there are subsets of patients who may have not responded to their satisfaction or our satisfaction on their 4/13 or 13 inhibitor, but they do on an IL-31 inhibitor like nemolizumab. And so it's always something to consider. Additionally, there's no reason not to think about starting nemolizumab first line, particularly for patients based on these cases that have prominent facial dermatitis or patients that have specific concerns about side effect profiles and AEs. Jim, you know as well as anyone else that our biologics are generally very well tolerated and have a very, very low safety concerns.
I think that that could be said across the board, correct?
Exactly. That's exactly what I'm saying. Across the border, biologics are considered very safe and have very minimal safety signals. However, even amongst our biologics, I would argue that nemolizumab may have the cleanest safety profile of our all of our biologics, particularly when we talk about, like you mentioned earlier, no conjunctivitis, essentially zero injection site pain, not just in clinical trials, but in real world patients as well. And when we look at the
Yeah.
placebo adjusted rates, at least for the short term study, the week 16 data, there's only four things. Even when we look at it in the long term, there's really not a big bump in safety signals.
Yeah, it really hasn't changed, but we being open to the fact that it's newer, we have to evaluate this over time and see if that stands out to be true or whether new things are going to come along. But I think that that safety profile and the efficacy that we can expect from it is extremely clean. And the other right, so I think the data shows that so far, and there's no reason not to think about that. But when you said about whether it could be the initial treatment or something that these patients come in and they're already on other treatments, both have been looked at. So if they were on other biologics or other therapies before systemically or not, it doesn't matter. They could respond in either case. Certainly they've been on topical therapies before, which all these patients have. In these trials, they were on them and they ran in on them the way it would be on the real world, whether it was a corticosteroid, sometimes a non-steroidal, to what was available. So it fit into the real world. So it doesn't matter if they were on previous treatments before or not. It still applies. Doesn't matter the gender. It doesn't matter the ethnicity. I mean, all of those things, none of it made a difference. I believe they even looked at body weight to an extent. So if they were heavier, they still responded, but I don't remember if there was a distinct cutoff on that. Do you?
Well, you're absolutely right, Jim, and it varies a little bit whether we're talking about nemolizumab in the PN trials, which are the Olympia trials, or the Arcadia trials for AD. For atopic dermatitis, the dosing is the same, irrespective of weight. For PN, there is a higher dose for higher weight patients,
Right,
but considering these are AD cases, let's focus in on AD. When we think about treating atopic dermatitis patients, what's the value proposition for nemolizumab? Well, one is that it's a single loading dose of 60 milligrams, so two injections, but then it's also Q4 weeks from the get-go. Right out the gates, you're doing an injection every 4 weeks with the possibility to flex to Q8 week dosing for atopic dermatitis.
right,
Currently, this is the only medication that offers you Q4 week dosing and then the ability to flex to Q8.
right,
Certainly, Jim, we do all kinds of things in our clinics off label, and we may do other things with different medicines, but strictly by the book, that's something that nemolizumab offers that's
right,
novel.
right. So I think that there's a lot of positives to nemolizumab to consider, and all I want to make sure, and I believe you want to do the same thing, is that clinicians understand with the different therapies what they potentially bring to the table, what the downside could be in certain cases. Fortunately, pretty uncommon, especially with the monoclonal antibodies. But even the Janus kinase inhibitors overall are pretty safe in this population. And then knowing your patient, decide what they're going to do. And then know that they have other options they could turn to. They're not backed against the wall, like you said. If they don't pick something first, they can consider that depending on how the patient's doing later. But you got to give them enough time to see if they're responding. So you think we summed it up pretty good, David, or does David Cotter's are his wheels turning, and does he have something else that popped into his head that he wants to say?
Jim, you know me too well. My wheels are always turning, but I think we did sum it up pretty well. I'll leave our listeners with one last thought. Currently, we've got six FDA approved medications to treat moderate to severe atopic dermatitis and more on the horizon. Hopefully, cases like these and these types of discussions help you navigate the treatment choices for your patients in your clinic. Certainly, anchor to clinical trial data and real world data, but talking through these nuanced patient cases to me highlights where one drug might shine over another for a certain patient phenotype. And if it helps you give just a little bit better care to even one patient in your clinic, then it was worth the listen today.
Exactly right. And I know it was worth the listen today because I learned a lot, especially when I was not the one doing the talking.